Thank you very much for the invitation to come to this nice meeting. And sorry, maybe this was. Yeah, that's better. Thank you. Feels more comfortable. Okay, in this beautiful place. So I will discuss a little bit about targeted drugs in melanoma. And here are some disclosures that I have been involved in advisory boards and steering committee. As you heard from the previous speaker, a lot of advances have been made in melanoma, so we are sort of leaving the simplistic model that every patient should have the same treatment and starting with targeted drugs. And you heard about the big successes with the immune active drugs. But I will also talk now about drugs targeting targets within the tumor cell. So this is based then on molecular alterations in melanoma, and this is just a simplified view of the most common and important molecular pathways involved. And most so far of treatments have focused on this pathway, the MAP kinase pathway, since it has been discovered that a large part of cutaneous melanomas have mutations in codon 600 of the BRAF gene. And this is just an old study we did in Stockholm. We could see that approximately 50% of patients carry such mutations. And this can also be visualized by immunohistochemistry nowadays. So this is a mutation-specific antibody showing BRAF mutant melanoma cells in a tumor. This has been developed then into a targeted therapy, and the first drug, vemurafenib, is shown here. It can actually stop the signaling and shut down the pathological signaling from BRAF through the MAP kinase and stop the increased cellular proliferation and lead to tumor effects very rapidly. And this is from the first publication that came out of the early trials. You can see that already within 2 weeks of starting treatment, the metabolism in the tumors has gone down markedly, shown by these PET scans. And the pivotal trial which led to approval of this drug was a randomized phase 3 trial comparing vemurafenib to chemotherapy with the established drug dacarbazine. 675 patients, called the BRIM-3 study. This shows the difference in responses. So this is a waterfall plot showing every tumor that has regressed below the line, whereas those that have progressed above. And you can see that the majority of patients had partial or some even complete responses to vemurafenib. Very few were intrinsically resistant compared to dacarbazine, where you have a minority of patients responding. This translated then into an increase in progression-free survival. These are the updated results showing approximately 7 months progression-free survival with targeted drug compared to less than 2 months with dacarbazine. And also this translates into an overall survival. So this was the second drug showing a survival benefit in advanced melanoma after ipilimumab. This led to approval in the United States and also in February of 2012 by the EMA in Europe, and the drug name is Zelboraf. And this is just some examples of patients that we treated early on. So this is a lung metastasis responding during Zelboraf treatment, and this is liver metastasis. And I'm not sure you can see this very clearly, but you can get very dramatic effects also on very large tumors, like this big tumor on the back of this lady who shrank and flattened completely with therapy. Following the success of the first BRAF inhibitor, there is an intense development of novel drugs, and this is a second approved drug, dabrafenib, called Tafinlar, and in the initial trial, you see that you get very similar results, showing response rates of approximately 60% and a very similar median performance-free survival of 6.3 months. This has also in the randomized trial been shown to be superior to dacarbazine and is now approved both in the US and also in the European Union. These new drugs have very novel effects, but they also have novel toxicities. And I will just mention a few of these. Particular for vemurafenib Zelboraf is that this is a photosensitizing drug, which is not the case with dabrafenib. This is a patient in the springtime in Sweden where the sun is not very strong. She forgot to put on a glove and burnt her hand like this. So we're very adamant that you need to instruct these patients to have very careful sun protection. And every patient who receives the drug Zelboraf also gets sun protection with a sun protection factor of 50 to use on their skin, on exposed skin surfaces. And this is very difficult to protect from otherwise because the sensitization, as shown by this study, is due to sensitization to UVA. So it is a long-wave UV light which penetrates, for instance, through a glass window and is much more difficult to protect from UVB. So this is a real concern for these patients. Another important class of side effects is actually that you can get induction of skin tumors, particularly on UV-exposed site by these drugs. And I will come back to that. Also, you have the early reactions with skin rash, as in this patient. You can get more severe reactions, just like the previous speaker showed that you can get very systemic toxic reaction called the DRESS syndrome, which is characterized by a rash, fever, eosinophilia, and also internal toxicities that need you to stop the drug, give high-dose systemic steroids, and sometimes you need also intensive care treatment and supportive care for the internal organ toxicity. Another problem for these patients is that you get hand-foot skin reactions, so they get swelling and tenderness of the palms and soles, which can be quite troublesome. And also, as I mentioned, you can get induction of squamous cell tumors in the skin, either keratoacanthomas, like in this case, but which are on the borderline on squamous cell carcinomas, and you can also get fully developed squamous cell carcinoma. So it's very important to collaborate with dermatologists to monitor the skin of these patients. These occur mainly on UV-exposed skin, and they seem to be occurring quite early, so probably it is a tumor-promoting effect of the BRAF inhibitor on skin cells already carrying mutations that predispose them to develop a tumor early on. There has also been a development of inhibitors to the protein which is downstream from BRAF, the MEK protein, and one such inhibitor has been approved in the United States, and it has shown similar activities, so you get perhaps slightly lower response rates when you target MEK as compared to the mutant BRAF, but also very similar rapid effects. And you can see that the target effect is on by showing that the ERK activity in the MAP kinase pathway is shut down by this treatment. There has been a report of a combination of these two treatments, so we actually target the same pathway with two different drugs targeting different proteins, and the early reports of this were quite promising. So compared to monotherapy with just a BRAF inhibitor, you could see that the combination showed an extended progression-free survival, which was better than with a single agent. So this has led then to a couple of large trials, for instance, with GSK drugs, dabrafenib and trametinib, in combination with dabrafenib alone in a large randomized trial. And there is also one trial comparing this combination to vemurafenib. And the first results of this trial were actually published in a letter about 2 weeks ago. And unfortunately, you see that this combination does not resolve the problem of resistance, because in this phase 3 trial you can see that compared to dabrafenib alone, the progression-free survival is less than 1 month. It's only about 1.5 months extended. So it is a significant extension of the duration, and it's accompanied also by a larger number of responses. But clearly, even with this combined treatment, the issue of resistance is a very big clinical problem. And there have been many studies, mainly in vitro systems, showing that there are multiple mechanisms of resistance. And this is an example in a published paper showing how dramatic this resistance can be. So this is a patient with multiple subcutaneous metastases before treatment, and after 15 weeks there was a complete remission, but 8 weeks later this patient had a rapid development of resistance and a recurrence of almost all of these lesions. And as I said, there are many mechanisms that have been shown to cause resistance in model systems. Many of them involve activation of the MAP kinase pathway, for instance by mutations in receptor tyrosine kinases, NRAS mutations, or downstream MEK mutations. You can also get activation of the PI3 kinase, AKT signaling, which may actually cause the tumor to respond less well to BRAF inhibitors. And there are many other mechanisms that have been described. Now, data are actually emerging from patients, and this is a very recent report showing a very elegant study where sequencing, deep sequencing, was performed on tumors before treatment and compared to the resistant tumors. And you could see then in about 40 different patients that there were likewise a lot of different mechanisms involved. So in many cases, the resistant tumor had developed NRAS mutations. Another mechanism is amplification of the BRAF gene, so that even though you have an inhibition, the gene product is so abundant that it cannot be inhibited by the BRAF inhibitor. Downstream mutations in MAP kinases, and many other mechanisms like mutations in the PI3 kinase or the PTEN loss. So this shows that this is a very complex issue, and you may have, even in the same patient, heterogeneity with several mechanisms contributing to resistance. And we have also studied a little bit in our lab using in vitro data. So we have used a BRAF mutant-sensitive melanoma cell line and exposed it to increasing doses of vemurafenib. And as you can see, you can induce resistance to high doses of vemurafenib in vitro. And if you look at the same cells, despite not having been exposed to a MEK inhibitor, they're also cross-resistant to the MEK inhibitor. And what we could see when we did the proteomics screening of these resistant tumors was that there were several alterations, and one of those was involving a signaling pathway with the increase of the expression of the c-MET receptor, which is a receptor for the hepatocyte growth factor and activates MAP kinase and has been implicated earlier as a resistant mechanism. And what we could see was that these cells, despite being resistant to BRAF inhibitors, they were quite sensitive to MET inhibition, and you could also overcome this resistance by combining. So these cells are resistant to the BRAF inhibitor alone, the MET inhibitor alone, but they are sensitive then to the combination of both. So this shows that this may be one possibility in the future to combine treatments rationally by analyzing the resistance mechanisms and giving combination treatment. And this, of course, emphasizes the importance that when we are treating patients with these drugs, we need to do translational research. We need to do biopsies, we need to do blood samples to understand much better the mechanisms of resistance and to try to develop predictive markers for long-term benefit to these drugs. Now I have focused only on the results of the 50% of tumors which have BRAF mutations, but another 20 to 25% of cutaneous melanomas harbor NRAS mutations. And it has recently been shown that with MEK inhibition, you can actually get good responses in a proportion of patients with NRAS mutations, just similar to those with BRAF mutations. So this shows that NRAS is now possible also to target, and there are many more studies, of course, involving this, trying to use targeted drugs also to the NRAS mutant tumors. So I would like to conclude with some of the issues I think are important for the future. We need much better predictive markers, not on early response, but on durable long-term response to identify which patients will develop resistance, and also hopefully to predict which type of resistance which mechanism will cause the resistance. Of course, we need to develop further combined therapies, BRAF inhibitors with inhibitors of other pathways. So far, BRAF and MEK inhibitor combinations have been tried, but there are now studies ongoing combining inhibition both of BRAF, MEK, and the PI3 kinase pathway. Combining the two new modalities, the targeted treatments with immune therapy, is also very attractive, of course. Unfortunately, the first effort to combine vemurafenib, BRAF inhibitor, with ipilimumab concomitantly was unsuccessful because this caused a lot of liver toxicity. So you cannot use this in combination, but rather sequence therapy. Of course, combining the targeted drug with more conventional cytotoxic therapy. Also, there is a development of looking at adjuvant treatment of stage 3 melanomas before patients have developed stage 4 disease. So there are two big trials using targeted drugs as adjuvant treatment, the Combi-AD combining dabrafenib and trametinib, and the BRIM-8 trial looking at vemurafenib as an adjuvant treatment. So we are looking forward to those results. Also, of course, we need to identify novel targets and also look at combinations of immunotherapy with other types of targeted drugs. And as I said earlier, the tumor heterogeneity of melanoma is likely to be a very big issue in the future. So you may have to combine treatments or alternate treatments so that you're able to affect both the proliferating, dividing cells as well as stem cells, which may be more dormant and may escape treatment with the targeted drugs, for instance. And there have been results now showing that maybe the tumor can actually adapt. So if you have a rapidly progressive tumor, treat this with a targeted drug, it may start to get to a more a dormant stage where the tumor cells are not growing so rapidly, and that may then cause relapse. So there are many further issues to address, but still I think you can see here that we are celebrating the successes of the new treatments in melanoma, which has really revolutionized the field. So it is a very exciting time to be working in the field of melanoma oncology. So thank you very much for listening.